Definition. The central nervous system, CNS, is part of the nervous system. It consists of the brain and spinal cord. The nervous system as a whole collects and interprets information about our internal and external environment and determines a response. Sensory information is transmitted to the CNS via afferent pathways from the peripheral nervous system, PNS. This information comes from various sources like specialized receptors in the skin, muscles, joints, special sense organs, and visceral receptors. The brain interprets this information, and messages are sent to target tissues via efferent pathways to make necessary adjustments or actions to ensure homeostasis. The brain is composed of nervous tissue and is responsible for responses, sensations, movements, emotions, communication, thought processing, and memory. It is protected by the skull, meninges, cerebrospinal fluid, and the blood-brain barrier. The brain is divided into two hemispheres, left and right, which communicate but are responsible for different behaviors, brain lateralization. The left hemisphere is more dominant in language, logic, and mathematical abilities, while the right excels in creativity, artistic musical activities, and intuition. Key parts of the brain mentioned include the cerebral cortex, frontal, parietal, occipital, temporal lobes, basal nuclei, thalamus, hypothalamus, pons, medulla oblongata, and cerebellum. The spinal cord is located within the vertebral column. It transmits motor commands from the brain to the peripheral body and conveys sensory information from sensory organs to the brain. It is protected by bones, meninges, and cerebrospinal fluid. The two major cells in the CNS are neurons, nerve cells, and glial cells, neuroglial. Neurons in the CNS have the basic structure of dendrites, cell bodies, axons, and nerve terminals. They can be categorized into sensory neurons, motor neurons, and interneurons based on function. Sensory neurons gather information from the environment and relay it to the CNS. Motor neurons receive information and transmit commands to muscles, organs, and glands. Interneurons are located exclusively in the CNS, connect neurons, process information, and are involved in both simple reflexes and complex brain functions. They are the most abundant type of neuron. Glial cells are thought to support and assist neurons in the transfer and integration of information in the CNS. They do not conduct action potentials. Four main types in the adult vertebrate CNS are astrocytes, microglia, oligodendrocytes, and ependymal cells. Etiology. The provided sources do not contain information regarding the etiology, causes, of conditions related to the central nervous system. Pathophysiology. The provided sources do not contain information regarding the pathophysiology, functional changes associated with disease or injury, of conditions related to the central nervous system. The text describes normal function. Management. The provided sources do not contain information regarding the management or treatment of conditions related to the central nervous system. Affective disorders. Definition. Mood refers to a pervasive and sustained emotional state that is experienced internally and influences nearly all aspects of a person's behavior. Mood disorders, also known as affective disorders, are characterized by significant disruptions in emotions, such as severe lows, depression, or highs, hypomania or mania. These are common psychiatric conditions that contribute to increased morbidity and mortality. According to the DSM-5, mood disorders are broadly categorized as bipolar disorders and depressive disorders. Bipolar disorders include bipolar I disorder, characterized by a full set of mania symptoms, bipolar II disorder, major depressive episodes and hypomanic episodes, cyclothymic disorder, subthreshold depressive and hypomanic symptoms, and other categories related to medical conditions, substance use, or unspecified symptoms. Hypomania is a milder manic state lasting at least 4 days without significant impairment. Depressive disorders include major depressive disorder, MDD, diagnosed by at least 5 specific symptoms over 2 weeks, disruptive mood dysregulation disorder, DMDD, in children-adolescents, persistent depressive disorder, PDD, dysthymia, depressed mood lasting at least 2 years in adults, and premenstrual dysphoric disorder, PMDD. Major depressive episodes can occur alongside persistent depressive disorder, known as double depression. Etiology. Mood disorders are influenced by various factors. The amygdala and orbitofrontal cortex are key brain regions involved in regulating emotions. Brain imaging studies suggest that abnormalities in these areas contribute to mood disorders. Patients with mood disorders often have an enlarged amygdala. Repeated episodes of mood disorders can lead to ventricular expansion. Neurotransmitters play a crucial role. Serotonin and norepinephrine levels are typically reduced during depressive episodes. Serotonin is the neurotransmitter most commonly linked to depression. Dopamine is also implicated, possibly decreased in depression and increased in mania. Pathophysiology. Neurotransmitter abnormalities are central to the pathophysiology. Reduced levels of serotonin and norepinephrine are typically observed in depression. Dopamine is implicated, potentially decreased in depression and increased in mania. Brain imaging studies suggest abnormalities in the amygdala and orbitofrontal cortex. An enlarged amygdala is often seen in patients with mood disorders. Repeated episodes may cause ventricular expansion. Management. The primary route to treat depression is to increase noradrenergic and serotonergic signaling. Avenues for treatment include blocking noradrenaline or serotonergic reuptake transporters, NET, SERT. This is the mechanism for serotonin and noradrenaline reuptake inhibitors, SSRIs, SNRIs, and tricyclic antidepressants, TCAs. Treatment also involves inhibiting the catabolism, breakdown, of noradrenaline and serotonin. This is the mechanism for monoamine oxidase inhibitors, MAOIs. TCAs inhibit the reuptake of serotonin and noradrenaline at presynaptic terminals, increasing their concentrations in the synaptic cleft. They also act as antagonists on cholinergic, alpha-1, alpha-2, muscarinic, and histamine, H1, receptors. Side effects relate to blocking these receptors, including blurred vision, constipation, dry mouth, orthostatic hypertension, sedation, and potentially cardiac dysrhythmias. MAOIs block the monoamine oxidase enzyme, which breaks down neurotransmitters like noradrenaline, serotonin, dopamine, and tyramine, thereby increasing their levels. Side effects include dry mouth, nausea, headache, insomnia. A dangerous interaction occurs with tyramine-containing foods, potentially causing a hypertensive crisis. MAOIs are indicated for patients who cannot tolerate TCAs and SSRIs. SSRIs increase serotonin levels by inhibiting the serotonin transporter, SERT, at the presynaptic terminal. This enhances serotonin activity. They primarily affect serotonin, having minimal impact on other neurotransmitters, leading to fewer side effects compared to TCAs and MAOIs. Side effects include little to no anticholinergic alpha-blocking effects but possible association with prolonged QT. SSRIs are the most widely used treatment for depression. SNRIs block the reuptake of both serotonin and norepinephrine, NET. A mild dopamine reuptake inhibition may also exist. Side effects are similar to SSRIs. Antidepressants are also used for anxiety disorders, OCD, eating disorders, insomnia, PTSD, and some chronic pain. Schizophrenia. Definition. Schizophrenia is a disabling psychiatric condition. It impacts around 1% of people worldwide. It ranks among the top 10 global disability causes. Many individuals experience substantial disability and incomplete recovery, facing challenges like social isolation, stigma, and high unemployment rates. Factors like poor diet, weight gain, smoking, and substance use are common, reducing life expectancy by approximately 13 to 15 years. The lifetime risk of suicide is estimated between 5% and 10%. Symptoms fall into two groups, positive and negative. Risk of suicide is estimated between 5% and 10%. Positive symptoms include delusions, hallucinations, thought alienation, and disordered thought. Negative symptoms include poverty of speech, flat affect emotion, social withdrawal, apathy, and attention deficit. Etiology. Schizophrenia's pathophysiology involves various molecular and neural circuit changes, but it is uncertain if these are causes or adaptive responses. Neurotransmitter abnormalities are central. Pathophysiology involves various molecular and neural circuit changes. No single model can fully explain all observed changes. Neurotransmitter abnormalities are central to the pathophysiology. Neurotransmitters involved include dopamine, serotonin, glutamate, and gamma-aminobutyric acid, GABA. The connection to dopamine was discovered when dopamine D2 receptor blockers were found to alleviate psychotic symptoms. There are four key dopamine pathways. Mesolimbic pathway. Excessive dopamine activity here is thought to contribute to the positive symptoms. Mesocortical pathway. Reduced dopamine levels here may underlie negative symptoms and cognitive deficits. Nigrostriatal pathway. Associated with extrapyramidal motor side effects caused by D2 receptor blockers. Tuberoinfundibular pathway, linked to hyperprolactinemia observed with D2 receptor blocker use. These pathways suggest distinct mechanisms for positive and negative symptoms. Management. Most current pharmacological treatments, typical neuroleptics, are aimed at dopaminergic transmission, despite the dopamine theory not explaining everything. All antipsychotic drugs have inhibitory effects on the dopamine D2 receptor. Being a dopamine 2, D2, receptor antagonist helps control the positive features of the disease, but has little effect on the negative features. First generation, typical, antipsychotics block D2 receptors. Second generation, atypical, antipsychotics block D2 receptors and serotonin receptors. All have other effects to varying degrees, including serotonin 5-HT2 blockade, may improve negative symptoms, histamine H1 blockade, drowsiness, and alpha-adrenoceptor blockade, postural hypertension. Typical antipsychotics inhibit dopaminergic neurotransmission, with best effectiveness blocking about 72% of D2 receptors. They also have noradrenergic, cholinergic, and histaminergic blocking action. Examples include chlorpromazine, pimozide, haloperidol, and droperidol. Atypical antipsychotics block D2 and serotonin receptors, most commonly the 5-HT2A subtype. Examples include clozapine, risperidone, and olanzapine. The main side effects of antipsychotics are on the extrapyramidal motor system. These include akathisia, restlessness, hours. Dystonias, involuntary muscle contractions, hours to days. Parkinsonism, weeks to months, characterized by rigidity, tremor, and loss of mobility. Tardive dyskinesia, months to years, characterized by repetitive abnormal movements of the face and upper limbs, thought to be due to proliferation of D2 receptors in the striatum. Parkinson's disease. Definition. Parkinson's disease, PD, also known as paralysis agitans, is a neurological disorder that affects movement control. It is the second most common neurodegenerative disease behind Alzheimer's disease. Parkinsonism is a general term for a group of neurological disorders causing movement problems similar to those in PD. It is a syndrome characterized by tremor, bradykinesia, slowness of movement, and rigidity. Etiology. PD is a multifactorial condition influenced by both genetic and environmental factors. Age is the most significant risk factor, with the median age of onset being 60 years and incidence increasing with age. There are cross-cultural variations in prevalence. Cigarette smoking is associated with a reduced risk of developing PD. The reasons are not fully understood, but nicotine-activating nicotinic acetylcholine receptors has shown neuroprotective effects in models. Caffeine is associated with a reduced risk, with coffee drinkers having a 25% lower risk. Caffeine acts as an adenosine A2A receptor antagonist and has shown neuroprotective effects in mouse models. Parkinsonism, the syndrome, can be caused by drugs, e.g. antipsychotics, metoclopramide, TCA, MPTP, vascular disease, Parkinson plus syndromes, multiple system atrophy, progressive supranuclear palsy, corticobasal degeneration, Lewy body dementia, and trauma. Pathophysiology. Movement control involves crucial neurons in the substantia nigra. These neurons communicate with the basal ganglia by releasing dopamine, DA, essential for fine-tuning movements. In PD, neurons in the substantia nigra progressively degenerate. This leads to a decrease in the amount of DA available for neurotransmission in the corpus striatum. This biochemical imbalance results in the typical clinical symptoms: tremor, rigidity, bradykinesia, loss of postural reflexes. Impaired dopaminergic neurotransmission can lead to increased corticostriatal glutamatergic transmission. Evidence suggests this imbalance includes overactive striatal aminobutyric acid, GABA, output. Microscopically, the pathological hallmark is the presence of abnormal cytoplasmic deposits called Lewy bodies, pounds, within neuronal cell bodies. These are immunoreactive for the protein synuclein. They are often accompanied by dystrophic neurites, Lewy neurites. Management. The primary therapy is the administration of drugs that increase the levels of dopamine, DA, or dopamine activity, in the basal ganglia. The secondary therapy is the administration of anticholinergic drugs that decrease ACH activity in the basal ganglia. The goal is to restore the balance between DA and ACH activity.
Drugs used to increase dopamine include levodopa, amantadine, dopamine agonists, bromocriptine, pramipexole, ropinirole, and enzyme inhibitors, carbidopa, selegiline, tolcapone.
Anticholinergic drugs like benzotropine, diphenhydramine, and trihexyphenidyl are used for motor extrapyramidal symptom management by decreasing ACH activity. Combinations, such as levodopa plus carbidopa, Sinemet, are also used. Seizures and epilepsy. Definition. A seizure is a transient behavioral change that may present with objective signs or subjective symptoms caused by abnormal excessive or synchronous neuronal activity in the brain. It is the clinical manifestation of an abnormal, excessive, and hypersynchronous discharge of a group of cortical neurons. Epilepsy is a central nervous system disorder characterized by recurrent seizures that are not triggered by an acute systemic or neurological insult. Epilepsy is one of the most common neurological conditions, affecting over 70 million people worldwide. Epilepsy is diagnosed when an individual has two unprovoked seizures occurring more than 24 hours apart, a single unprovoked seizure with a high risk of recurrence, or a diagnosis of an epilepsy syndrome. Understanding the difference between seizures and epilepsy is crucial. Epilepsy often requires long-term treatment. Etiology. Seizures and epilepsy result from an imbalance between excitation and inhibition in specific regions of the central nervous system, CNS. There are many ways this balance can be disrupted, leading to a variety of causes. Epilepsy can result from various genetic and acquired factors. Resection procedures in neurosurgery are used for lesional epilepsies caused by developmental abnormalities, tumors, vascular malformations, or trauma. Pathophysiology. The underlying issue is an imbalance between excitation and inhibition in the CNS. Epileptogenesis refers to the sequence of events that transform a normal neuronal network into a hyperexcitable one. Seizures are characterized by excessive neural activity, caused by both increased action potential firing rates and increased synchronous firing. Management. Pharmacological treatment using anti-epileptic drugs, AEDs, is a primary approach. AEDs primarily work by enhancing inhibition over excitation, thereby preventing or stopping the initiation and spread of seizure activity. AEDs can be categorized based on their main mechanisms. Inhibition of NA-dependent action potentials. Examples: phenytoin, carbamazepine, lamotrigine, topiramate, zonisamide, lacosamide, cenobamate. Objective: prolong inactivation of Na+ channels, reducing ability of neurons to fire at high frequencies. Inhibition of voltage-gated Ca² channels. Example: phenytoin. Reduce the flow of Ca2+ through T-type Ca2+ channels, diminishing action potential generation. Examples: valproate, ethosuximide, topiramate.
Blocking of glutamate. Examples: lamotrigine, felbamate, perampanel. Lamotrigine suppresses glutamate release. Perampanel is an AMPA antagonist.
GABA enhancement. Examples: benzodiazepines and barbiturates. Binding of GABA opens the GABA-A receptor, increasing Cl influx, which increases membrane polarization and reduces neuronal excitability. GABA activity can be potentiated by positive modulators at the GABA receptor, barbiturates, benzodiazepines, topiramate, reducing GABA metabolism, vigabatrin, valproate, topiramate, inhibiting GABA reuptake, tiagabine, and increasing GABA biosynthesis, gabapentin. GABA reuptake inhibition. Examples: valproate, gabapentin, tiagabine. Opening of potassium channels. Example: ezogabine. Activate voltage-gated K+ channels, providing a stabilizing influence by hyperpolarizing the membrane. Some AEDs, like topiramate, act on multiple mechanisms. AEDs are effective for nearly 80% of individuals. For the 20% with drug-resistant epilepsy, neurosurgical interventions may be beneficial. This involves removing or disconnecting a specific brain region. Types of neurosurgical interventions include resection procedures, like temporal lobectomy with hippocampectomy for intractable temporal lobe epilepsy, discrete lesion resections, lobectomies, hemispherectomies, and corpus callosotomies. In well-selected groups, 50 to 80% become seizure-free after surgery. Neurostimulation techniques are palliative options for drug-resistant epilepsy when surgery is not possible or has failed. Common neurostimulation techniques are vagus nerve stimulation, VNS, and deep brain stimulation, DBS. VNS was the first approved device and has shown significant seizure frequency reduction. DBS involves implanting electrodes into the anterior nucleus of the thalamus, demonstrating similar efficacy to VNS. Both VNS and DBS are associated with improved quality of life, fewer hospitalizations due to status epilepticus, and reduced mortality.